Managing a medical practice in Illinois involves navigating a layered payer environment that is significantly more complex than the national standard. In April 2026, Kodiak Solutions released a comprehensive analysis of the healthcare revenue cycle. Across more than 2,300 health systems, they found a 25% increase in net revenue leakage year over year. That percentage translates to more than $48 billion in uncompensated care and denials across the system. Initial claim denial rates surged in 2025, reaching 11.6%. 1 in 9 claims is now rejected on the first submission. Medicare Advantage plans are a primary driver of this trend, producing initial and final denial rates more than double those of traditional Medicare. The core mechanic here is payer behavior. Insurers are systematically pushing back harder on anything requiring clinical documentation, prior authorization, or a medical necessity review. As a result, final denial rates climb above 14%, while the rate at which providers successfully overturned those initial denials actually declined. The gap between your practice's perceived performance and the actual deposits hitting your bank account is a measurable industry-wide surge in revenue leakage. While the national data looks grim, the specific structural complexity of the Illinois Medicaid system creates an entirely distinct set of local challenges. The baseline state standard sounds reasonable. The Illinois Department of Healthcare and Family Services sets a 180-day timely filing window for non-institutional Medicaid claims. This chart shows how the state standard conflicts with HealthChoice Illinois. 5 managed care organizations enforce their own submission deadlines. A claim valid under the 180-day window is frequently denied if it hits an MCO enforcing a strict 90-day cutoff. These rules are in constant flux. The Comprehensive Billing Manual for HealthChoice Illinois providers is updated every quarter. In the November 2025 version 35 release, the coding for community-based behavioral services changed, moving LPHA review from Group A to Group B. Foundational rules change mid-year. On the Medicare side, the MMAI program ended on December 31, 2025, transitioning to fully integrated dual-eligible special needs plans on January 1. Practices that missed that workflow update sent weeks of claims to the wrong payers. Similarly, the HFS practitioner fee schedule updated in January 2026, but carried retroactive effective dates back to December 31st. Practices unaware of the update missed a window to resubmit claims for higher payments. Missing any of these specific state updates carries a severe penalty: immediate, unrecoverable denials. The intersection of these conflicting deadlines and retroactive updates creates a margin for error that few in-house teams are equipped to track daily. Even if Illinois payer rules and filing deadlines were entirely stable, local practices would still face challenges due to an unstable workforce. Across the industry, business operations and front office turnover is severe. End-of-year 2025 data shows billing staff turning over at an annual 35% rate. Every time a specialist leaves, the financial penalty is measurable. Recruiting, onboarding, and training a replacement costs between $25,000 and $30,000 per departure. This stacked bar chart builds the fully loaded cost of an in-house Illinois billing specialist. Beyond the $55,000 to $75,000 base salary, add benefits, training overhead, and turnover costs. Furthermore, a replacement takes 3 to 6 months to reach full efficiency.
Human training takes months. Meanwhile, major payers at the industry level update their billing policies approximately every 72 hours. These compounding staffing inefficiencies contributed to the 11.1% year-over-year increase in practice operating expenses reported in 2025. Relying on standard in-house staff to manually track hyper-fast MCO updates while managing 35% annual turnover often leads to diminishing returns. To understand what successful billing looks like, we use the HFMA MAPKey benchmark. High-performing practices consistently achieve a clean claim rate of 90% or higher. Reaching that 90% threshold requires abandoning a single universal submission workflow in favor of separate tracking protocols strictly customized by payer category. A standard sequential billing queue is replaced by parallel processing that catches errors before claims leave the building. When denials occur, a 30-day countdown timer begins. Formal workflows categorize, assign, and track every rejection to closure, preventing permanent revenue leakage. To prevent clinical and medical necessity pushback, practices must focus on upstream documentation integrity, ensuring the notes capture the true complexity of the encounter before coding begins. Organizations that maintain this dedicated revenue integrity infrastructure see a 68% improvement in their net collection rates. Reaching the 90% benchmark in Illinois is difficult for generalists. Achieving that level of accuracy requires a specialized, state-aware revenue cycle architecture. Smart practices in Illinois are moving away from the in-house generalist model. They are shifting to specialized co-source teams. Staffingly operates specifically on this model. They place dedicated external billing specialists directly inside a practice's existing EMR. These are AAPC and AHIMA credentialed specialists. They are assigned to a single practice, learning your specific workflow and payer mix, rather than operating in a shared pool. This external team brings a technological advantage, utilizing AI augmentation for smart claim routing and predictive workload management to keep AR queues from aging unnecessarily. This line graph compares the economics over a 3-year period. The bottom line is the predictable $20,800 annual cost of a Staffingly seat. The top curve shows the escalating cost of an in-house seat, factoring in 35% turnover. The external team operates within an audited framework of security standards, including SOC 2 Type 2, ISO 27001, and HIT trust coverage from day one. Co-sourcing shifts payer compliance from an internal administrative vulnerability to an external managed specialty, executing at a lower total cost. The final hurdle for most practice owners is the perceived friction and operational downtime of switching billing teams. This sequence shows the integration steps for a 14-day go-live timeline. It moves from kickoff to EMR connection, staff onboarding, go-live, and finally, weekly dashboards. Implementation speed is immediate. EMR access is established within 48 hours of the kickoff call, and the team begins managing your billing queue in week 1. Weekly KPI dashboards give practice leaders real-time visibility into throughput, accuracy, and ROI, eliminating the need to compile manual reports from internal staff. To address revenue leakage directly, you can initiate a 14-day pilot to test a state-aware billing architecture